This is Healthcare That Clicks, where healthcare, innovation, and big ideas collide. No fluff, just the strategies reshaping the future of care. Here are your hosts, Ryan Kelly and Will Moon.
Hello, everyone, and thank you for joining Healthcare That Clicks. We have a special episode of the podcast today, discovering the UMMC Center for Telehealth, the Center of Excellence at the University of Mississippi Medical Center in Jackson, Mississippi, one of two centers of excellence in telehealth in the entire United States. With me today is Dr. Saurabh Chandra and Dr. Tearsanee Davis, two seasoned and polished experts in the world of telehealth who are going to come to us today and tell us a little bit about telehealth at UMMC, where it is, where we expect it to go, and everything in between. My name is Ryan Kelly. I'm the host of Telehealth That Clicks along with Will Moon. Will is out today, so I'm going solo along with Dr. Chandra and Dr. Davis. But very happy to have you here with us on the podcast. What I'll do with our two guests today is just kind of go around, let them tell a little bit about themselves first, and then we'll dive into a little bit about telehealth. So Dr. Chandra, would you like to start, and we'll go to Tearsanee next.
Saurabh Chandra, thank you for hosting me today. I am the Chief Telehealth Officer here at the Center for Telehealth and Emerging Technologies at UMMC. Prior to coming to Mississippi in 2020, I was leading the enterprise-wide telehealth program at a large health system in New York and was getting tired of doing it in an urban area. And right before the pandemic, I thought that, telehealth to work in somewhere it's really needed. And we had heard about UMMC's telehealth program. It's recognized nationwide, and it's been a privilege and honor to work here in Mississippi, a state that I have come to love, and I enjoy working with my team members like Tearsanee.
I appreciate it. And we're happy to have you here. You've done a great job since you've been here, and the center's just grown remarkably in a new facility that I'm just seeing for the first time. They've been in several, and they keep getting bigger because we keep picking up more staff here and more projects and programs. Happy to have you here. And Tearsanee, you've been here even longer and have done some great work. So tell us a little about you.
Yeah, so I currently serve as the Director of Clinical Programs and Strategy here at the Center for Telehealth and Emerging Technologies. We have a new name. I'm a nurse practitioner by training, family and psych, but my experience, most of my clinical experience has been in the family arena. I love the work that I do here because it actually impacts the people. For me, it's all about the people. Similar to what Dr. Chandra says, my passion comes from my experience as both a consumer of health, a product of rural Mississippi, and then also my experience as a primary care provider, and understanding that the challenges that people face in rural communities are not necessarily worse than those in urban, but it's different. And there are other barriers. Although the work we do is not only for the rural community, that's who I'm thinking about, as we are building programs, is those people who have other challenges beyond just what we call access, other than access to specialty services. For many, it is basic care. That's kind of where I am, and that's why I stay and do the work that we do.
We're really appreciative. You've done such a remarkable job here at UMC. Grown telehealth to many of the facilities in Mississippi and some outside. Yes. So it's been really remarkable to see that growth and development. So I want to ask specifically about telehealth in a second, but let's talk about the Center of Excellence for a moment, because that's something many people just don't know what a Center of Excellence is. There's two of them in the United States, one of them here at UMMC. Tell us a little bit about what this designation is, what it does, and where you may see us kind of going from here.
So this is a designation that we got in 2017. I was not here then. And this is a testimony to the work that was done here over the years, starting way back in the 1990s and early 2000s, and the work that many team members, including Tearsanee and Greg Hall, who is the Director of IT, still here, contributed to. And they were really nationally recognized leaders here. Christy Henderson, who was here leading the program in the 2010, 2014, she did a great work. So all of that was recognized by HRSA, which is a federal agency, and they designated us as well as MUSC in South Carolina to basically do innovative work in the field of telehealth and actually promote the field of telehealth, set up innovative telehealth programs, and then show how it actually works, what works, produce evidence-based best practices, do rigorous analysis, do research, and what I call is being a laboratory and a lighthouse. You actually do all the work, and then once you have the good results, then you disseminate and you actually help others all over the country, replicate and use your expertise in promoting telehealth in all over the country.
Yeah.
And I'll have Tearsanee add to that. If you're here longer than that, I actually submitted the first application in 2017.
Okay.
Well, I mean, he really did sum it up. That's basically what it was. And the way we were approached, with the opportunity, or the way we approached the opportunity was, let's see, how the work that we have done and the bit of infrastructure that we had at the time could advance telehealth.
Right.
And in order to advance it, we first needed to understand why it was not advancing. So a lot of our work in that first iteration of the Center of Excellence was on evaluation, like why aren't people doing, particularly in our rural areas, because, those are the people that need it. These are the organizations that need it, our FQHCs, our rural health clinics, smaller family practice clinics, and things like that. And those people need access to the specialists who often live in the urban areas, if we can call anywhere.
Urban for Mississippi.
Urban, absolutely. So we did a lot of that work. It is not, I think we do need to be clear about this, it's meant to promote UMC or to build programs that are only beneficial, to UMC. And with this Center of Excellence, one of the biggest, I would say, benefits or values that it has brought our Center for Telehealth and Emerging Technologies is it allowed us to build that research team, that we did not have the resources to build at the time when we were primarily a clinical. So we're excited about the work that we've been able to do and looking forward to the opportunity to do more work. It's kind of like the momentum is there now. We certainly want to be able to continue to do this type of work. And you mentioned expanding outside of Mississippi. That is one of our priorities, not only so we can say we are outside of Mississippi, but more so we can show that the work that we're doing can be done in other places. I mean, there's no reason for us to be gatekeepers of all the great things that we have learned. Get that out there.
Well, it's definitely been a pride point for Mississippi how fast we grew in telehealth. Legislation back 2013, 2014 that allowed us to be able to cover telehealth through insurance, and now largely it is paid at the same rate as in-person care. Not entirely, but in many cases it is. Many of our providers are using it, although I want to dive into that in a second from the barriers. And we were one of the national leaders in Mississippi to be able to do this. Now, other states, of course, have caught up, and that's great because we want to expand this. We don't want to hold the keys to the kingdom. There's obviously still a limit on how many people are using telehealth right now, and I know it's frustrating to all of us. So during COVID, but for pre-COVID, we judge the world now. It's like the birth of Christ. It's COVID, pre-COVID, post-COVID, right? So you've got, there was a little uptake of telehealth. It was kind of gradually going up. Then, of course, world shuts down, spike in utilization, telehealth, everything comes back to normal, and it drops significantly, as we knew it would. But it has settled higher than where we started. But it is still settled, and the trajectory is still carrying up a little bit, but I know it's frustrating to all of us because we know telehealth to be such a great point of access, and yet it's still not utilized as well as I know we all wish it would be. So kind of carrying along those themes, what are some of the reasons that y'all have found why telehealth is not being utilized by providers and understood as well by patients?
So I can speak a little bit from the provider perspective initially. I think one of the biggest things is kind of the inconsistencies in the regulations, and it changes so frequently. So when I think about a large organization, even like our own, in some of our departments, they put a process in place that meets the guidelines, or they build their clinical program around regulations. We can get paid for this if we do this, and it changes, and it keeps changing. And so they have to ask themselves the questions, is it worth it for us to keep, changing what we do? Or They have to think about the resources that it takes internally to even do, the service. So I think that's one big thing.
Okay.
The other thing is just provider behavior. If I'm accustomed to going into a clinic and seeing whoever is presented to me, that's a lot more comfortable, and that's easier for me to do. If I'm at work, I'm productive, right? But for me to have to take some extra steps, to connect with people, we lose control. You lose control of what's happening on the other side. And I think that it's just provider behavior. In many cases, one example is like remote patient monitoring. I believe that there are many providers who see the benefit in remote patient monitoring, who would not necessarily be opposed to putting their patients on remote patient monitoring, but in the course of their regular workday, it is not coming to mind that this is a tool that I can use.
Right.
I need to assist. So it will take time to change the way providers think and approach healthcare, to even think about that I have a telehealth solution right here, in my organization. So
we've had similar issues with non-telehealth things. So I think of smoking cessation billing codes and other wellness and prevention things we do, focus on mental health, or even oral health. These are all challenges we have in primary care. People come in, they have an upper respiratory infection. Well, the last thing you're thinking about is their mental health, or that they have an infected cavity that's causing a bacterial infection, unless it's being presented acutely in the clinic. This is a similar kind of thing. Someone comes in with a chronic illness. You probably know about chronic care management and RPM, remote patient monitoring, but are you thinking about actually putting them on a program like that to help monitor and diagnose and treat those comorbidities and get them off of insulin or reduce their body mass index by a certain amount? Probably not.
Right.
Because again, it's not that you don't think it's valuable, it's just not part of your process.
And it's the question, what do I have to do?
Yes.
What is standard practice? So
That's right.
As clinicians, if we're caring for a patient, there's this standard practice that if I'm doing this, I'm doing what I'm supposed to do. But then there's I'm going to do what's standard, and then I'm going to go above and beyond, to try to reach whatever the goal, is. So I think, again, it's lots of things. And that's one of the reasons, I'm going to stop in just a second. But that's one of the
perfect. This is
why getting the telehealth education into our educational programs is so important, because that's a new set, of clinicians coming out. So if they're already exposed to telehealth and how it can, be a part of their practice and enhance care, they're more likely to remember it because it was presented to them in school. They've been doing it in their clinical rotation and all of that, than the provider who's been practicing 20, 25 years, who's accustomed to doing it a certain way. I feel like they could be the catalyst for that change.
Absolutely. I'm wondering, we talked about AI in a previous podcast, and I have a healthy fear of AI, but I also know the power that it can create and some of the proper utilization of it in the clinical practice. And a lot of it is documentation. It's, doing notes in the EMR, auto-populating codes that would be appropriate for billing. Those are fantastic. It gives the life back to the provider. They can have interactions like this versus them being on a computer and typing and asking the occasional question. I mean, it's going to transform healthcare, in my opinion. However, I also wonder, and just tell me if you've seen anything related to this, I could see, along with the AI's documentation and coding, is providing recommended treatment protocols for those patients. Of course, this is one of the things we think about with AI, but easily CCM and RPM could be one of those. It's going to recognize there's multiple comorbidities. It would also be able to pull in what type of insurance they have and whether it's covered or not, and then make a recommendation that we put them on remote patient monitoring for some number of months because of those comorbidities to reduce those issues, and maybe even have a target goals recommended. It ought to be pre-programmed in, but if we program it to look for those sorts of things, I could see that being a really good auxiliary to that provider in there who maybe not thinking about it because someone comes in because they've got stomach pain. Maybe it's something more serious, but that could also be an alternative that would be recommended that would be part of their treatment plan. Have y'all seen any research or anything that's existing right now that you think revolves around that idea?
There's a lot of research and a lot of ideas that are, percolating even of what we do here, and you're exactly right. if you take an example of remote patient monitoring as it exists today, is basically we are providing more or less the same kind of management monitoring to all patients. And that may not be producing the best results because the patients who are, have multiple morbidities and have higher acuity may need closer monitoring. So what AI tools can and it's really exciting and it's happening, and there are some data, like what they can do is risk stratification. They can risk stratify based on your clinical characteristics, and then you can create individualized plans for patients tailored to what they really need. And then, so that's how, like, hey, okay, my nurse wants, needs to monitor the patient, and need monitoring and data 10 times for this patient in a month because they are more sick versus 2 times in a month. So you can do that. You can also then do some prediction based on data that is out there, and your something called digital twinning, that you can create a simulated, similar patient population and how they interact, how often they go to the ED, and you can create, like, okay, this patient has maybe predicted to go twice in the ED in the next few months. What are the signs and symptoms to actually predict and prevent deterioration so that they don't end up in the ED and hospitalization? So those are some of the really cool tools that AI algorithms are already providing. Now they need to be validated in a larger population and also a specific population, because what may work at a different place does not necessarily work with our own population. So a lot of exciting areas, and one thing that I'm really excited about is, and I want to mention and then I'll stop, is, patient engagement and adherence is such a big thing for remote patient monitoring, because even our own program, we see 30-40% times the patients are, they drop off, and there is continuously we are trying to see how we can keep them engaged. Think about it, that my nurses and other team members, everybody has a bandwidth, like 100 patients, 200 patients, and but what if my AI avatar, who speaks like my nurse and actually interacting with the patient every day, calling them up, talking to them in the voice, and they interacting with them and understanding and getting, how they're feeling and keeping them engaged and increasing the bandwidth of our team to do more clinical work.
That's right.
I mean, it is going to be a game changer.
It will.
So we are very excited about it. We are very excited about those possibilities. Now, with everything, you have to be very careful. As the more decision support, as you were mentioning about, documentation that is less clinical decision that you are relying on, that is more administrative tasks. So the risk to the patient is less. The more you move into the arena of using them for clinical decision support, the more is the risk.
That's right.
And so it's going to be a pretty exciting thing.
Well, and that's one thing I always say up front with AI is I never wanted to replace a human. I wanted to significantly augment a human, so where we can go X what we could normally do by not being bogged down in the things that a machine could do for us.
Well, one of the simplest ways that I think about AI, because I've witnessed what Dr. Chandra was saying. I've seen it demoed, and I'm like, I love it. But would it really be, are we ready for that?
Right.
When I say are we ready, I mean like the clinician. Are they ready to relinquish that type of control?
Tell them about your experience, your team's experience with AI Scribe.
They loved it. Yes. So we used AI Scribe, and we had some of our psych providers, and several of them came, and I read their notes, so I know how intensive, how their notes are so long.
Yeah.
And I've tried to get them to simplify, their notes. Like, this is what you need to say. I was taught less is more. Yeah. Say what you need to say and move on. But I had one in particular that came, and she wasn't resistant to AI, but she was just like, I don't think I have a problem, with my documentation. I'm okay with it. I'm thinking, lady, you are writing 2 and 3 pages, every time, whether you're copying and pasting or what, it's still taking time. But she agreed, she was like, sure, but I'll do it and see, and had a positive attitude about it.
You might could do a side-by-side comparison.
She came back, it was probably 2 weeks later after she started, and was like, I had no idea, that I was spending that much time, that I could save this much time.
Right.
because you still have to go back and validate.
You have to validate.
And I
Absolutely.
told them that. I set the stage, and I think this is important too when you talk about adoption of any kind, is you have to set the stage for everything that could go wrong.
Yes, absolutely.
And set the expectation. Like, this is not going to replace you reviewing this chart, reviewing this note, making sure everything is accurate. There will be times when you have to go put something in, that it didn't pick up and all that. So they knew that up front. But she was like, I'm spending like 5 minutes.
Right.
Going back. But it was also picking up things that she would not have documented.
Yeah.
One of the things we were really impressed by, which is what's making it very tough for us to embrace other scribe solutions, is that it could even pick up that who was talking, who was speaking. So
not all can do that.
Right. So in our pediatric visits, that was really important because we often have a liaison. We have the patient, and we also have like a parent, or a guardian in there. So being able to distinguish that the liaison said this, the parent said this, or the child is moving about the room and it requires, much redirection. Yeah.
And little things like that could be helpful later on from a mental health standpoint, because maybe it's going to be evidence of ADHD or something that would be documented even early in a primary care visit.
Right. And it also had back to what you were talking about treatment suggestions. We didn't follow those as our treatment guidelines, but it made me think about, what if I'm accustomed to taking care, maybe I'm the NP that likes ADHD, so I get most of my patients are the ones that, are suspected as having ADHD. But then this particular time I've got someone we think it may be bipolar disorder, right? So maybe I don't treat a lot of bipolar disorder, people living with bipolar disorder. The suggestions would be so helpful.
It would be.
That even say assess for this. So it's not telling me, what to prescribe for them, but it is helping me through my assessment. And so if you have that enough, it's going to teach you.
That's right. Well, and I think about, so there was a press release today about a new Lyme disease vaccine that's coming out. Lyme disease, it's treatable, bacterial infection, but vaccine, it kind of makes me think, all right, so Lyme disease, you don't see that much. You don't. Deer-borne ticks, you don't see that much, but here in the South, it's here. So if you're treating someone and they've got, arthritic-related symptoms, they've got fever, you're probably, and like my age, I've got arthritis in various joints, I might have fever, I'm probably going to think it's a virus, right? But then it might even prompt you, check and see if they've been hunting or if they've been camping. If they say yes, what area? Appalachia, maybe do a Lyme disease check. I mean, just something that you wouldn't think, you might catch later if they get worse. But you might be able to run some tests up front, which, mind you, now this isn't the goal, but it's additional revenue because you're running some additional tests that you could catch, but it's treating the patient. It's increasing the value of that visit, and it's augmenting things you wouldn't see normally. You're going to catch, you're a nurse practitioner, you're going to catch the normal things, right?
You're going to catch the things that you see all the time.
Exactly.
There could be that one that you're like, I don't.
It could be life-saving. It could be early signs of a heart attack or a stroke.
And it could save money, too, for the patient in the long run. Because as you just mentioned, we would eventually find out that it's Lyme disease, but how many visits? How many visits before we...
Or if we could see that someone is... pre-diabetic and they're not even showing symptoms. They're thin. They eat healthy. But maybe it's type 1.5 where it's like late onset. Things you wouldn't catch, but a lifetime on insulin is expensive. Let's say they're on Medicare or Medicaid and they're a lifetime on insulin, or they lose a limb. Now they're on disability. We can catch that early on. There's a plug to all of our governmental people who are watching this. Think how much taxpayer money we could save just by catching something early on from prevention and utilization of this technology. It's amazing.
So you bring up something that I feel is important when we talk about telehealth adoption and the value too, is that it has to be a longitudinal commitment. Like, we're not going, I can get a visit sooner if I use telehealth. But if we're looking at the overall value, a cost reduction, all of that, we have to look at it for a long period of time, like across the continuum. So even that patient living with diabetes or heart failure, all that, we've got to look at years. It may take years to really see the benefit of that. And sometimes it's not. It doesn't take that long. Like an RPM patient, someone
Instant.
someone who has been in the hospital 4 times in 1 year, but now we've got them on RPM.
That's right.
And they aren't going to the ER as much. They haven't been admitted at all because now the provider is like, you're safe to be at home because I know that you have support at home.
That's right. Able to cut back medications that they're
Yeah,
on.
yeah.
They're healthier. They're happier.
Yeah.
Clear
Able
savings.
to test things out and give reports back, versus let me throw this medicine,
Yeah.
at you and see what happens. So
That's right. Just apples to apples, it's saving pennies on the dollar. Not to mention the lifestyle benefits and the socioeconomic benefits in society of having someone who's healthy and able to be part of the workforce versus someone who's on disability or at home sick all the time.
yeah, that's a good point you make about the workforce. When we were first trying to really get RPM adopted here, and I still feel like we still need to do it, not just at UMC, but just Mississippi in general, is we have a very large population of people who do have uncontrolled diabetes, uncontrolled hypertension, heart failure and all of that. They're still working because we have to work, And I use my dad as an example. When he was diagnosed with diabetes, he had an A1C of 14. He worked every single day. For a student tied to worked every single day. So the regulations at the time required that the person would have 2 hospitalizations or ER visits within the past 12 months. My dad had not had any hospitalizations. He'd been in the hospital 1 time in his entire life. So he would not have been able to.
He didn't want to break the streak. It's a good streak.
He was working. He was working.
Yeah.
That's what people do. And so that was one of the big barriers to really getting the right people on the program, was the laws, the reimbursement regulations, and all of that. It's very important for us to think about how do we use these tools to not only make it easier for the providers and the patients, but to help people have the highest quality of life possible. Help them be able to work as long as they want to.
So Joe Rogan recently had someone on his podcast talking about, it was a health-related topic. And those podcasts, they can jump all around. You might be talking about healthcare one second and aliens the next, and you never know. But they talked about how much liability is on the corporate side if you've got someone who's driving a forklift or a semi-truck or something like that, and they're having these chronic health issues, driving down the road, going 70 miles an hour, pulling a, I don't know how many ton trailer behind them full of something, and then they have a stroke because they didn't get the health care that they needed, knowing that there's an issue. Not either they got to get those hours in, even though there's regulations around how much you can drive. Let's take it a forklift, someone working around heavy machinery, someone working around dangerous chemicals. Anything goes wrong during that process, that's tremendous liability for that company. And then, of course, we've got some great corporations in Mississippi that have rolled out telehealth among their employees, the corporate telehealth side. The benefit there for them from, again, healthy workforce, so the difference of presenteeism and absenteeism. Absenteeism, you're home sick. Absenteeism, you're at work sick and you're working at like 25% capacity. So you're there, but you're not really there. Versus a workforce that is, maybe you're sick, you're 80%. It's a lot better than 25% because you're treated, you're able to do it, you don't have to take off. So many benefits, but the liability of that company knowing that they're taking care of those employees loosens or lowers that liability threshold substantially, not to mention those other benefits.
Right. And the employees feel like their company cares.
Yeah.
About them.
Absolutely.
With several of the companies where we provide urgent care to the employees, right, in the setting in their workplace, so they don't have to go and miss work and go to a doctor for an appointment for 2 or 3 hours, take time off for minor health problems.
So I remember this from several years ago. I was fascinated not only that you did this, but how affordable it was.
Yeah.
You were offhand. I know the prices have changed probably.
Yeah, at the time it was $10 per member per month.
Yeah, it's like that's laughably
and
expensive.
And we reduced it even more.
Did you?
Yeah, we reduced it even more than that because we looked at how much time, how much are they really using this,
right?
And came up with something that was more.
So you're under $10
yeah,
per
because
person.
What you have to think about is that not every employee is going to use it.
That's right.
And our team is not only doing that. Our team is working in our direct-to-consumer program, but
which I have used, by the way.
See, it worked well. But yeah, I mean, healthcare doesn't have to be expensive. Now, I will tell you, the groups where it is most popular is our self-insured corporations, because they're going to pay the cost one way or another.
That's right.
So they are more amenable to paying for my employee to have access to this now, us being aware, even if we do find something. We have actually taken care of people whose blood pressures were at stroke level.
Yeah.
You know, and they had to be taken off work so they could go see the hypertension and, you know, and get on the medications and all of that. And their corporations welcome that. They're like, how much time do they need? Whatever they've got to do.
That's right.
Because they understood that it's going to help them and they're going to be able to work, you know, and it's going to help our operation as well, because we'll save money if we're proactive about taking care.
That's right.
You know, them. Even before we added the mental health component, we had some corporations that knew, like, this employee is having some issues. We know it's not in the contract, but how much would it cost, you know, for you to see them, to take care of them?
And y'all can do customized contracts like that.
Exactly.
Wow, that's great. What all, so standard in a contract like that for corporations who want to cover their employees? Is there any minimum size? And then what all is covered under the traditional contract for them?
Yeah, so we really don't have a minimum size.
So you can be a two-person business, you can still do it.
If you're a two-person business, I mean, but overall, we accept any insurance. So if it is a two-person business and they have insurance, then that would probably be the route that they want to go. For our much larger corporations, this one in particular that's on my mind, I'm not sure why, but they did not cover mental health services. Their insurance did not cover mental health services. So that was something that we had to contract, you know, with them on the side. At the time, it didn't cover remote patient monitoring either. But they knew they had a population of employees that could benefit from that. Yeah. So they paid for, you know, remote patient monitoring. But most of our corporate accounts are for the urgent care services only. Unlimited visits.
So it's a similar interface to the direct-to-consumer.
Yes, that's what started it.
Okay.
So we started with the corporation. We were testing it out. Do people even want this? You know, what does it look like? What does our price point even need to be? You know, that was funded by the Mississippi Development Authority and the governor's office at that time. And then several of them stayed on once that funding ended. And they did give us feedback, you know, on what was needed, what was helpful to them. That's when we went to the per member per month, unlimited visits. So the corporation is paying $10 per person for them to use us as much as they needed to.
That is so inexpensive.
On their time. Yeah. That was the other thing. Yeah. They didn't dock them for any time associated with that visit, which was great. And then we just add on, you know, they come back and say, what about mental health?
Well, and the great thing of that model, of course, this is a teaching facility, and of course, even lumping the Center of Excellence on top of it, it's like you said, it's a laboratory and a lighthouse. I love that terminology. So you're able to provide the service, but then by doing that, it gives you additional capacity, and it probably also gives you a research element in there as well, because now you're seeing the common conditions that are coming in, you're able to see the outcomes, you're able to demonstrate the power of it, and then this helps you provide additional quote-unquote ammunition for other states to expand and grow in those areas as well, right?
Right.
And even for our own state to convince, you know, policymakers and others, you know, and regarding the value of the program, and to be able to sometimes for the insurance to cover the different programs that we come up with.
So speaking of our state and policy, I want to dance around specifics here, but we've had a bill come up in Mississippi the last few years, and it's failed the last few years, unfortunately, but it has taken our expansion of telehealth policies from back in 2014, and it would say instead of just covering at the same rate of in-person care, it would say it would pay at the same rate as in-person care.
They are the drivers, and they are, you know, what you are alluding to, coverage and payment parities. There are more services that are covered and payment parity as well. But overall, I think we have seen more recognition by payers on the value. And I would want to point out how grateful we are. For example, you know, we were asked to go and, you know, we were honored to present at the state Senate Insurance Committee. But then, you know, state Medicaid reached out to us to ask us, what are your challenges? And they are asking us and say, how can we help you? I mean, that was amazing. That is what you want. And so I think as people recognize the value, and we are able, as you said, do good research analysis and demonstrate the value of different programs, slowly people are recognizing and falling behind. When you were talking about AI, I just wanted to add that many PCPs, when they are sending information to the provider for the provider-to-provider thing, either they fax like 50 pages and they say, hey, bulk, because nobody has that much time in their offices. Now a specialist is now reviewing 50, and it takes them an hour to figure out what's going on, and then there's not enough information that they needed to make some recommendation.
The reimbursement is not worth it
Right.
either. That's the other piece.
It's not going to cover for an hour's time.
Right.
Then it becomes like they are not incentivized to provide, even though their heart may be into this. And I was talking about, we're talking about AI. We have now developed a technology working with a vendor where the PCP can take the 50 pages, whichever form, PDF, Word document, doesn't matter.
Scans it, reads it.
Put it uploads it in the software, and that software output is a summary of all the 50 pages in a 2-page and tailored to a specialist. So
with bullets.
With bullets, and probably with some recommendations in there too, right? That's amazing.
But definitely the bullets,
And we are hoping now, we are testing it out at our academic medical center.
Great.
And then our hope is that we can then test it out in the entire state with other providers. And if that is the case, do rigorous analysis, show impact on outcomes, healthcare utilization in the ED, hospitalization outcome, and then hopefully then convince the payers. So I would say that we also need to do some, better rigorous analysis to make the case for the payers.
Well, and it makes perfect sense. So you're not replacing the provider. The provider is still the one delivering care. That provider, though, we're grossly inadequate number of providers in the state, particularly like you mentioned, rural areas, but even here in Jackson. So if you're going to tie up a specialist who makes hundreds and hundreds and hundreds of dollars an hour with having to read 50 pages of notes for one patient to provide a consultation for another provider who probably makes hundreds and hundreds and hundreds of dollars an hour, if you could just speed up that provider's time, use the God-given knowledge that they've been given, but speed up the ability for them to come to that determination, then you've just saved thousands of dollars, hours of time, and probably even save that patient to really actually, because no one's actually going to read all that. They're just going to skim. They're probably going to miss some things. They can read it faster, provide that note summary, and some recommended treatment plan, which the provider can and cannot use at his or her will. It just speeds the whole process up. And insurance should be happy with that because it's saving them money ultimately among the multitude of their population.
Right. I also think about the patient satisfaction aspect of that as well. When the patient presents, if they have to come to that, provider clinic to actually be seen by them after an e-consult, the provider knows more about them than they would normally know. Absolutely. So they can just kind of cut to the chase. And not have to, because what happens when you send them that 50-page summary is they're going to look for some specific things, and the rest of it they're just going to ask the patient.
That's right. They're going to ask the patient, and you're going to have to tell the whole story again.
You're going to tell the whole story again.
And most of your visit with that provider, you're having to pay again. It's just rehashing what you already told the last guy, the last lady.
And also duplication of services. That's a big thing too. Is they would know whether they've had all these before and would know what they need to be looking for.
Absolutely.
So I think that's a big benefit.
There was a time when telehealth and in-person were considered like separate, different modes of healthcare delivery, each in its own silos. But with the pandemic, we know that hybrid and integrated models where there's a continuous, seamless care that is provided to the patient, and it's not about telehealth or in-person. It's about what is the best modality for an individual patient and understanding what their need and circumstances is and what fits them best.
Right. And it's a case-by-case basis,
Case-by-case basis. And I think where we want to go is creating those integrated models of care. And that would need, reduce the ability of bad actors to provide care because we are wanting it in an integrated, seamless workflow.
There are checks and balances in place.
If you're not integrated, having that kind of emphasis and making sure that right programs are allowed to flourish create its own check and balances rather than punishing on reimbursements and penalties and other things.
100%.
That's what it's
Yeah, I agree completely. And so, Mississippi Telehealth Association, one of the sponsors and partners of this podcast here, Tearsanee being our president, I should have actually mentioned that from the outset, president of the Mississippi Telehealth Association. One of the goals of the association really is somewhat two-front, or maybe three-front. Number one, which I think we're close on, and you just touched on this, Dr. Chandra, is we don't want there to be a division between in-person care and telehealth. They should be seen as just different modalities. Car and truck. Which way do you, or maybe car and bus or something, car and airplane. You get into a place, you just choose the vehicle that is
best suited.
And one may be better than the other. Telepsych is a good example of telepsych, the and patient satisfaction than in-person counseling nowadays because of stigma, because of the awkwardness of being in person, especially among Gen Z and Gen Alpha. They really don't like being in person, sharing their feelings. They'd rather text it to you. So telepsych is a much better one for them. Now there's others that in person gets a little better than telehealth. And now we're talking about what's the ideal modality of care. What's the cheapest, easiest, and best for the patient. And telehealth often wins that battle, not always. And there's some things you can't do with telehealth. Even though I know technically you can operate with a machine where someone can be across the world, and that we've got broadband that can do that now. Most of the time you're going in person and you're going to have an operation in a hospital or a surgical center. You're not going to have someone from across the world doing it. But we could.
And I feel like we have to ask the question too. Once we determine that it's safe to do, we have to ask the question: Is my decision the difference between someone receiving care or no care at all?
Exactly.
Like would they get this? So it may not be the ideal situation, but is it better for me to do as much as I can do?
That's right.
Via telehealth, or at least offer it.
And I found myself so many times in various healthcare spaces saying the same thing. Would some care be better than no care? Well, in almost every instance, the answer is yes. Some care is better than no care.
Nice. That was one of the things in our corporate program that I feel like really helped it be, embraced as much as it was, is we would tell the corporations when we were talking to them, we would say we can help a person make a decision about whether or not they should seek care.
Yeah.
Versus, the person is at home and they're like, should I go to the ER? Should I not go to the ER? We all know what the ER bills are like just for signing in and getting triaged. And if they can use our service, we're potentially saving them a visit.
Absolutely.
Because there are things that we can guide them through. This is not an ER visit. This is a primary care visit.
And even,
let's get you
even the ERs that have a primary care clinic at the front, or they might triage you and take you over to the clinic. You're still sitting in a waiting room. You're still sitting in a clinic room. You still are hours and hours to see a provider.
And you're off work.
Scared, and you're in a foreign environment that's usually cold and maybe a little sterile looking, versus being in your living room and your dog's sitting next to you and you're on a telehealth visit. You're probably a lot more stable and comfortable in your living room than in that cold environment, even if the care is the same. So I'd rather be the comfortable, convenient one at home or at work or wherever I am. And we are all healthcare professionals. We understand the system. And it's still a little ominous and still a little scary. Think of the person who has never, third grade, fifth grade, 10th grade reading level, educational level. They don't have a clue how all this works. And they shouldn't, because they don't teach this. We have to figure it out on our own. And it's so built to be confusing. A telehealth module, in my opinion, and probably Mel's opinion, is just so much of an easier way to go about getting that level of care. And if they need more, they find out they need more from the comfort of their house without being scared, without being intimidated, feeling more comfortable in their environment.
This is a plug for us. I was trying not to do too many plugs, but I will do a plug for our urgent care program in particular. Is if they do seek care from us, we're providing care and we deem that they do need a higher level of care, we don't just say to them, you need a higher level of care and end the visit. We're trying to figure out how to get you that higher level of care. Yeah. So we do help them navigate through the healthcare system.
That's
even so much as things you need to say.
Yeah.
Good. Like you need to make sure you tell them this. We have called and made appointments We have found out what was in their community because they didn't know, because we're referring to their community. We're not referring to UMC. Because again, we want to make sure that they're getting care that they can continue.
So if they called you from Macon, Mississippi, you're going to refer them to like the Noxubee complex.
We're going to find out what's in Noxubee, what's in Starkville, what's close around you, because they're going to need follow-up.
Yeah.
They may be able to do what it takes to get here for one visit, but are they going to come, monthly? Are they going to come for all of these tests? So we're putting that patient care, that revenue, all of that right back into that community.
That's great. All right, we talked about the Center of Excellence. We talked a lot about telehealth and AI. Anything like where you think the center's going in the next few years?
I want to wrap it up on my side by saying that I think we are all very proud of the Center of Excellence, and so are everybody in the state. We are actually, this round of funding is ending in September, and we are in the midst of preparing for a redesignation application when it comes out in the next few weeks. So I just want to leverage the best wishes of your audience and all Mississippians to wish us the very best in our redesignation application so that we can continue to do the good work that we have been doing.
Absolutely. Tearsanee, anything else to add?
No, I'm not. I'm glad to have the opportunity for us to share a little bit about our perspectives, on things. We know our perspectives can change, but this is where we are now, and we need help. I mean, it requires everyone. I will say the last thing is how we got here. So, and I won't spend a lot of time on this, but I do want to say that UMMC Center for Telehealth got to the place where we are by doing things because it was necessary, and not. This was back before there was reimbursement, back before there was a path, a pathway to get paid, back before, before many people.
And that's really important, just quick to pin that. Telehealth was a thing before anyone paid it. So this is not just like, if anyone wants to say, oh, it's just a money grab or it's just another chance to get more paid. This was invented way before anyone paid for the service because we believed in it.
Yes.
I'm sorry, keep going.
Yes, that's exactly what I'm saying. We believed in it, and it ties into what Dr. Chandra said for his reason for being in Mississippi is telehealth in Mississippi was truly birthed out of a real need.
Yes.
And we could not make the decision if there was no money motivation, at the time.
That's right.
We were not getting paid for it. No one was getting paid for it. And then I think back to now we're at a place where someone who doesn't have to practice in Mississippi chooses to be here, to work because the need is there. The fertile ground is there. So we're not a fly-by-night company that said, hey, we can get paid for this and make a whole lot of money. And this is why I believe the Center of Excellence is very important, and we're really rooting to get this opportunity again so that we can continue to contribute to the body of knowledge that informs our policymakers, so that there is a greater uptick, our motivation for advancing telehealth. So that's the thing I wanted to leave was, because when you're talking to an organization like ours, or you're talking to a new, organization that just got into business in the past 2 or 3 years, we're coming from different places.
That's right. There are many of those right now.
Yeah.
And Ryan, we cannot finish this conversation without mentioning the RHTP. We are very excited about the one of being, telehealth being one of the 6 initiatives.
That's right.
For the state of Mississippi in their application. Hopefully there will be opportunity to.
So I'll mention this is being recorded on March 24th, 2026. You're looking at this months later. The RFP as of today has not come out yet, but as Dr. Chandra mentioned, in Mississippi and in many other states, telehealth and telemedicine is one of the tranches of money that has been designated in the state's application for the Rural Health Transformation Program, part of HB 1 from 2025, the One Big Beautiful Bill. The state has been awarded an element of money based on an application to the federal government, and then there are applications through requests for proposals, RFPs, that will be coming down to different entities, and I'm sure UMMC's Center for Telehealth, it will be one of those entities that will be applying for some money. There are many others as well. Many people watching this podcast may be interested or may be planning to apply. As of today, we do not have those RFPs yet. Maybe next week, maybe 2 weeks after that. We don't know. If you're watching this 2 years later, this is old news to you. But right now we're waiting. But yes, absolutely. We're happy that telehealth is a huge part of what Mississippi is doing. It's a huge part of what Dr. Mehmet Oz and Robert F. Kennedy Jr. have from HHS. They've said many times that technology and the integration of technology in healthcare is the biggest driver, which literally is why we have this Healthcare That Clicks podcast, because we believe in the intersection of healthcare and technology. And of course, that is really what telehealth is in the broadest scheme. It is the intersection of technology interfacing with healthcare in some capacity, whether it be exactly what we talked about today or wearables and the connectivity to a provider or anything like that. There's so many different elements of what telehealth means. And all of them are in the bullseye of what this money will go to. We're in support of you all getting some good money because you grow rural outreach substantially through all the different programs you have here, tele-emergency, tele-ICU, tele-stroke, you mentioned tele-psych, urgent care, all the things you do. It grows access throughout all of Mississippi, particularly rural areas.
I think we are all united then, because at the end of the day, it's all about improving the health outcomes for the patient for the people in our state.
Absolutely. Well, Dr. Saurabh Chandra, Dr. Tearsanee Davis, thank you for being a part of the podcast today. Again, this podcast is sponsored and hosted by the Mississippi Telehealth Association. If you are not familiar with the Telehealth Association, we encourage you to go visit us online at www.mstelehealth.org. We have a variety of resources on the site that we'd love for you to check out. And we also have a special link, fairly new link on there, where if you have any questions about telehealth, either in or outside of Mississippi, fill that link out and send it to us. Our staff and our board will help to get answers to you. We get calls quite frequently, definitely on a weekly basis, from providers all over the country asking questions about how do I do telehealth in Mississippi, or how can I treat patients outside of that state. And we certainly help to answer those questions to the best of our knowledge. So we encourage you to go and check out our site. We thank you for viewing our podcast today, episode 5